Now it is my great pleasure to introduce Marianne Hutton. Marianne has over 30 years experience helping people understand their nutritional needs. She is a registered dietitian, medical nutrition therapist, and owner of Finally Fit Nutrition Services, which offers general nutrition, weight management, and specialty services for people with diabetes and kidney disease. Marianne received her Bachelor of Science degree in Nutrition Science from Mercy College at the University of Detroit, and thereafter became a registered dietitian. She is also board certified both as a renal specialist and diabetes educator. Marianne has worked with the Veterans Administration Outpatient Clinics, Northern California Center for Wellbeing, Santa Rosa Junior College, Santa Rosa Memorial Hospital, Sutter Community Hospital, Healdsburg General Hospital, Fresenius Medical Care, Satellite Dialysis Center, San Francisco General Hospital, and the University of Michigan Medical Center. And she is a volunteer with the Children's Diabetes Foundation of the North Bay. She also has her own private practice in Santa Rosa, California, specializing in diabetes and kidney disease. And she even had time to come here today. In 2007, Marianne co-authored a book, Kidney Friendly Foods, with celebrity chef Katie Lee Joel. And her professional affiliations include the American Dietetic Association, California Dietetic Association Renal Practice Group, Consulting Nutritionists of California as a past board member, Diabetes Care and Educational Practice Group, and the National Kidney Foundation. She was chair of the 2010 National Spring Clinical Conference Program Planning Committee. Marianne is a published author of 2 kidney-friendly cookbooks and also of journal articles in the Manual of Nutrition and Diet Therapy, American Journal of Kidney Disease, and Journal of Renal Disease. Please give a very warm welcome to Marianne Hutton.
Thank you very much, Scott. Wow, that was quite an introduction. Did I do all that stuff? Thank you very much. I'm so pleased to be here today, especially since we weren't supposed to be here. It's the 22nd of May. It was supposed to be Armageddon yesterday, so we're here when we're not supposed to be here. So I'm so happy that we're all here together today, and pleased that you've taken time on a Sunday to come and learn about kidney disease and the diet, and I hope that you'll take away some pearls today that'll help you and maybe some family members. So without further ado, let's get started. So we're here today to learn about the diet for chronic kidney disease. And there are several different stages of kidney disease, and I know that many of you here have different interests as far as the diet goes. So it's kind of challenging to talk to a large group like this when you have so many different stages of kidney disease and different questions. So what I did is I put together a set of objectives for us. And the objectives that we're going to try to meet today is that I'm going to talk a little bit about the risk and prevalence of developing chronic kidney disease. And I'm going to give a brief overview of some diet and lifestyle changes proven to delay the progression of kidney disease, chronic kidney disease. And we're going to be talking about the importance of finding a registered dietitian who specializes in, and we'll talk about Medicare coverage just a little bit. Today we're going to be talking about the GFR. How many people here, how many of you know your GFR? Do you know your GFR? Okay, I see half of you know your GFR, the other half of you don't know your GFR, and some of you might not even know what is a GFR. So the GFR is the glomerular filtration rate, and you know that your kidney is a filter. And so this is one of the measures that we use to determine how our kidneys are functioning. If your GFR is less than 60 for greater than 3 months, with or without kidney damage, you are said to have chronic kidney disease. And usually people, if they've had a transplant, are at a GFR of 60 or lower. So that would be stage 3 chronic kidney disease. So the key determinants of kidney function is the GFR, and also another marker of kidney function is protein in the urine. So the kidneys are supposed to keep waste products out, to let waste products go out, and to hold protein in. And so think of your kidneys as a colander, if you will. And the colander in the sink that you put your grapes in and you're cleaning off the grapes, the kidney is the colander with the holes in it. And the grapes are the protein. Well, if the kidney is faulty and failing a little bit, the holes in the colander are larger and the grapes fall through. That's protein. And the protein is going from the blood into the urine. So in other words, your kidneys, the colander, that is supposed to hold the grapes in, hold the protein in the blood. But a kidney that's damaged allows the protein to leak out of the blood and into the urine. And that's said to be a colander, the holes are too large. So there's different ways to tell if you have kidney problems, but the GFR and urine microalbumin test are the two main ways that you're going to know if you have any issues with your kidneys. People that have diabetes should always have annually a urine microalbumin test, and it's a very simple test. You just give a urine specimen, and that should always be done at least annually for someone with diabetes. Now the GFR test is an easy test as well. Whenever you get a blood test, if they do a chemistry panel, that is mandatory that they have the estimated GFR on that chemistry panel, and it's calculated based on your creatinine, which is a measure of your kidney disease. And it's a complicated equation, but it's very simply reported in your blood test, in a chemistry panel specifically. Does anyone know what KDOQI stands for in this room? Who can tell me what KDOQI stands for? Kidney Disease Quality Initiative, outcomes. Kidney Disease Outcomes Quality Initiative. Anyway, that was a group that determined there are different stages of kidney disease, and the value in that is that when we know what stage of kidney disease you're at, we know what therapies you need or what we need to look for as healthcare practitioners to better help you. So you want to know what your GFR is, and that GFR is listed on the far right of this table. So your GFR is over here, and a healthy GFR is greater than 90, as you can see. And when you need dialysis, your GFR would be less than 15. So who's had a transplant would be around here, presumably. If you have stage 1 kidney disease, then your GFR is above 90. So the higher the GFR, the better. If you have stage 2 kidney disease, you have a mild decrease in the glomerular filtration rate, and your GFR falls between 60 and 89. If you have stage 3 chronic kidney disease, you have a moderate decrease in your glomerular filtration rate, and your GFR is 30 to 59. Stage 4, you have a severe decrease in your GFR, and your GFR ranges between 15 and 29, and so on. So again, we can see that there's specific courses of action that happen in each of the stages of chronic kidney disease. So at stage 1, you're getting a diagnosis, and the doctor or your healthcare team is treating other conditions that go along with stage 1 chronic kidney disease. Can anyone think of what are the two major conditions that lead someone to chronic kidney disease? What would be if we were going to pick two major conditions?
High blood pressure.
High blood pressure would be one, and what would the other one be?
Diabetes.
Very good, very good. Diabetes would be the other one. So we're going to treat the comorbids and then slow the progression of the disease. And that comorbids are other diseases that go along with chronic kidney disease. At stage 2, your physician's going to estimate your progression of your disease. Stage 3, we're going to evaluate and treat potential complications, of which there are many. And it's stage 4, we're going to prepare for renal replacement therapy, which is otherwise known as dialysis. And stage 5, we're going to provide renal replacement therapy and education. Now personally, I like to see education start as early as possible, because I believe that nutrition and diet is medicine. But that's going to be my bias throughout the whole talk, because I believe very strongly that if a lot of people would see a registered dietitian early, like yesterday, they wouldn't have the problems that we have today. I think preventative care is where it's at, and I feel very strongly about that. I think we need to start with our children. I think we need to start yesterday with all of us. And You can see a registered dietitian. I don't think people are being referred very often. I'm not sure what's up with that, but people would do well to get a nutritional evaluation, and that's called medical nutrition therapy. So again, the GFR is important for you to know what stage you're at. According to the KDOQI guidelines, stage 5 chronic kidney disease, you can be at stage 5 and not be on dialysis, or you can be at stage 5 and need dialysis. The way you would determine whether or not you need dialysis at that point is with your healthcare team, but you'd probably be becoming very malnourished, and you'd have a loss of appetite. And the dialysis is a life-saving therapy that would help you get your appetite back so that you'll start feeling good again. Nutritional compromise happens when the GFR is between 28 and 35. And that's when you really see people get into problems with their nutritional status, and then their chronic kidney disease really starts to go faster and faster because there's all kinds of issues along with nutritional compromise. According to KDOQI, a low-protein diet should start with a GFR of less than 25. Again, I like to start things earlier. Now, you don't have to wait until your GFR is 25 to get on the proper diet to avoid kidney disease. And medical nutrition therapy is covered by Medicare when the GFR is between 13 and 50. But you can get medical nutrition therapy anytime you want. So as far as risk factors and prevalence goes, a lot of people I think it won't happen to me or anyone I know. How many people have chronic kidney disease? They say the national average is 1 in 9 have chronic kidney disease and don't know it. Now in my home state, and you probably can hear by my accent, I'm from Michigan, 1 in 8 people have chronic kidney disease and don't know it. So it's a serious problem. And this is a quote by David Moskowitz. The American people saw unforgettably how federal, state, and local governments failed the people of New Orleans just 3 weeks ago. What the American people don't realize is how they've been shortchanged by the past 3 years. Minorities are much more affected by kidney failure than whites. There's a dialysis boom on Indian reservations. So I just wanted to mention that I'd like to see more people, Native Americans, Asians and Pacific Islanders here, African Americans, Latinos. We need to reach out to more people on this important issue because we can prevent these kinds of things from happening. They are preventable, and a lot of people think they aren't because they see their mothers, their fathers, their grandfathers, their aunts, and their uncles on dialysis, and they believe that they can't prevent it. And there's nothing further from the truth than that. Now, again, regarding prevalence, you can see how the disease has increased over time, and so more and more people are developing chronic kidney disease. As I mentioned, I'm from Michigan, and look at the estimated number of people in Michigan. 940,000, right? Let me go back to the other slide. That shows, I mean, not in Michigan, throughout the country. Look at that. So our disease is progressing. We're up here now. We're up here somewhere there. So this is not a disease that's going away. And diabetes itself is a growth industry. So a lot of people are surprised when I tell them that 1 in 3 people have diabetes and don't know it. And diabetes is a growth industry, and so half of the patients in the dialysis clinics that I've worked at have type 2 diabetes. Now, sadly, when I work in the dialysis clinics, when I work with people with diabetes, they say, what kind of diabetes do I have? Do I have type 1 or type 2? And I'll explain to them what kind they have, and I'll tell them the differences between the two diseases. And they'll say, oh, I got the good one. I got type 2 disease. That's the good one. Well, no, it's not. Because the dialysis clinics are filled with half of the people there have type 2 diabetes. So we can talk about that a little bit later too. So anyway, how do you find your GFR? It's a blood test, and I already mentioned that. The rate of kidney failure, again regarding prevalence, it's 4 times greater among African Americans. 4 times greater. And so African Americans make up about 13% of the United States population, but they comprise 32% of patients treated for kidney failure, giving them a kidney failure rate that's 4.2 times greater than that of white Americans. When you have these situations, you should have a special diet, that's for sure. And you would get a nutrition prescription if you saw a medical nutrition therapist like myself. And there are a lot of dietitians out there in the community that provide medical nutrition therapy, so you can find one in your community, anywhere you are. So the cause of a CKD, chronic kidney disease, is high blood pressure, diabetes, heart disease, glomerular nephritis, kidney cancer, and polycystic kidney disease. And what can happen as a result of kidney disease that's entirely preventable is malnutrition from not wanting to eat, not making enough blood. Anemia happens when you have chronic kidney disease because your kidneys are responsible for making a hormone called erythropoietin. And that erythropoietin stimulates the bone marrow of the bone to make red blood cells. So when I first started working in the field of dialysis, we were hanging blood at everybody's chair side. We were giving them transfusions. Everyone at the clinic always was getting a transfusion because the kidneys are responsible for actually producing blood cells. And I never realized that. So I thought I'd share that with you today. So when you get tired and you get anemic, you don't feel like eating. And so this is one of the complications of chronic kidney disease that is completely treatable. And I want to stress to you all these things are completely treatable and many of them are preventable. High blood phosphorus is another complication of kidney disease. Again, completely preventable, completely treatable. The body robs the bones of hardness, and it puts the calcium in the places in the body where it shouldn't belong. And so what you get with hyperphosphatemia, or too much phosphorus in the blood, is you get hardening of the veins and arteries. And so high blood potassium is another complication, and your body could get too acidic and maybe too many infections. Those are all complications. So these are all risk factors on the screen right now that you can change. Protein in your urine, high blood sugar, obesity, high blood pressure, tired from not making enough blood, inactivity, bone disease, high blood cholesterol, low good cholesterol. These are all things that you have control over. And when you meet with a dietitian like myself, we don't work on all of these things. We work on one at a time, just baby steps. That's how you take care of this. So interventions, and you probably want to know, well, what can I do? What can I eat to slow the worsening of kidney disease? So when you get kidney disease, there are 3 ways to treat it, basically. There's a transplant, there's renal replacement therapy, which is also known as dialysis, and there's a low-protein diet. That's when you are before dialysis, before you need dialysis. Why don't people go on the low-protein diet? Because there's been some controversy about it. The reason is because if you follow a low-protein diet without supervision by a trained medical professional, you're going to get in trouble. And a lot of people think, oh, I can do this myself. But they can't. And studies have shown that without the guidance of a dietitian who knows what he or she is doing, you're probably going to get malnourished. So that's why you don't see a lot of people put on a low-protein diet, or that's one of the reasons. But a low-protein diet can prevent the progression of kidney disease. There's no question about it. I have people on a low-protein diet in my practice that don't even need to worry about their phosphorus and other issues because of that low-protein diet, and it's kept them off dialysis for years. So I'm here to tell you that that works. It's something that you wouldn't do on your own. It would be dangerous to take it on yourself. You wouldn't see it, for a really important legal matter, you wouldn't probably do it on your own without consulting an attorney. And the same thing is with a therapeutic diet. You shouldn't take these things on. It's in your best interest to see an expert just until you get started, or until you get, really competent at managing it yourself. I can't tell you how important that is. So that's why the low protein diet has gotten a bad rap over the years, and that's why one of the reasons why you don't see people on it, because there are a lot of people that fail the low protein diet because they don't have the right guidance. So medical nutrition therapy slows the progression of kidney failure and possibly delays the need for an artificial kidney. It prevents or minimizes loss of interest in food. It helps make blood pressure normal. It helps keep you strong, healthy, and out of the hospital. And it translates nutritional changes that are proven to work into a meal plan that's understandable and practical. So this slide shows us that the problems as a result of chronic kidney disease begin early. And so here's high blood pressure in the red bar. And you can see with the GFR of greater than 90, there's high blood pressure already before somebody has even gotten down here. So the high blood pressure is here when the person has a GFR between 60 and 89. And as you can see, it's even getting worse with the GFR between 30 and 59. And then here it is with the GFR between 15 and 29. So there's hypertension. In the yellow, a person's unable to walk. Your functional ability goes down as your GFR gets lower and lower. Malnutrition starts to happen. As the GFR goes down, all these problems go up. Let's see, the hemoglobin, that tells us if you're anemic. That's in the white bar. Look at how the anemia rises. And so when you get anemic, you don't feel like eating. You're too tired and too sick. And so anemia happens early too in CKD. So we know now what to look for at what stage of CKD you're in. So when I meet with someone who has chronic kidney disease, say their GFR is in here, in this range, I know exactly what I'm looking for when I'm going to talk to the patient. The phosphorus of greater than 4.5 will destroy your kidneys. Absolutely will destroy your kidneys. So this, you can see the phosphorus level rising as the GFR goes down. Now, there's a lot to be said about all these things, so I'll just keep moving along. Does anyone know who Alonzo Mourning is? Who's Alonzo Mourning?
Basketball player.
Basketball, all right, good. And he said, once my doctor began treating my kidney disease, my greatest challenge was the constant exhaustion. Fortunately, my doctor explained that anemia was causing my exhaustion and that people with serious illnesses like kidney disease may be at increased risk for anemia. And then you can get it treated. This slide shows that even though people are being treated for high blood pressures are not well controlled. And it's imperative that you control your blood pressure. Now, it's interesting, high blood pressure causes chronic kidney disease, but if you didn't have high blood pressure and you got chronic kidney disease also causes high blood pressure. Isn't that an interesting relationship? So if you don't have high blood pressure and you get chronic kidney disease, you will have high blood pressure. So which meal is the best choice here? I'm going to throw in a few little slides on nutrition since that's what I do for a living. You've got 3 ounces of grilled salmon seasoned with lemon and garlic powder, a half a cup of whole grain pasta with olive oil, red wine vinaigrette, garlic and basil, and a half a cup of frozen vegetables. On the other side, you have 3 ounces of grilled salmon seasoned with lemon and garlic salt, half a cup of whole grain pasta with Alfredo sauce, and a half a cup of canned vegetables. Which one do you think is the best choice? The one on the left? Why is that?
Low sodium.
A lot less salt. There's about 80 milligrams of sodium in the menu on the left and about 860 on the menu on the right. So controlling blood pressure is very important, and this is a pretty busy slide, but the bottom line is that there's a lot of things you can do to control blood pressure. You can lower your sodium intake, you can get physically active and physically fit, you can limit alcohol consumption, you can get your body mass index in a healthy range between 18.5 and 24.9. That's another question I have for you. Do you know your BMI? Do you know what a body mass index is? Your waist circumference. If you're a man, you shouldn't have a waist circumference greater than 40 around the umbilicus area, or like above your hip bones. If you take a sewing tape, a measuring tape, man shouldn't have a waist circumference greater than 40, and a woman shouldn't have a waist circumference greater than 35. That puts you at risk for a lot of different diseases, including diabetes, heart disease, and cancer. About the food label, I couldn't have a nutrition talk without talking about a food label. Here's the total grams of carbohydrate. That's important if you happen to have diabetes. The sodium intake in milligrams is right here. And then the serving size is so important. For one serving, 1 cup. Who eats a cup of anything anymore these days? Our portions have gotten pretty big, haven't they? I know that I ordered a small yogurt at the frozen yogurt store the other day, and it was in a cup this size, and they put this much in it. They swirled it all the way up to the top. And so small portions are pretty large, really, these days. Okay, so here, this slide shows the expected outcomes that we can get from lifestyle modifications on high blood pressure. Here's your systolic blood pressure reduction, and that's the top level of the blood pressure number. And here's the different things that can lower your blood pressure. So weight reduction lowers your systolic blood pressure by 5 to 10 millimeters of mercury. The DASH eating plan lowers it by 5 to 8. A sodium reduction lowers it 2 to 8 millimeters of mercury. And think what would happen if you even lowered it more than that. Most Americans eat, I don't know, 7,000, some 10,000 milligrams of sodium a day. So this is one of the reasons why we start with where a person is at. If a person is currently eating 7,000 milligrams of sodium a day, going from 7,000 to 1,000 is a pretty big jump. So we take you down gradually. That's how I normally do it. I help people wean themselves off of sodium. Physical activity lowers your blood pressure. And alcohol intake can lower your blood pressure if you can control that. And then the combination can really seriously lower blood pressure. But you can see at stages 1 to 4 what the sodium intake should be in stages 5. And I put on this slide, do you need to open your eyes to what you may be eating that is high in sodium? And the reason I put that on that slide is because when I meet with someone, the doctor will say to me, Marianne, would you meet with Mr. Jones? He's in the emergency room all the time because he can't breathe. And so I meet with Mr. Jones, and Mr. Jones says, you don't have to worry about me. I know quite a bit about sodium. I read the labels, and I follow a low-salt diet. And then I say, and so really he has no interest in seeing a dietitian. So then I'll say, okay, so do you mind just humoring me? What do you normally have for breakfast? And then what do you think Mr. Jones will say? Cereal. That's right. Or not only cereal, but milk. That's right, milk. People don't think of sodium being in cereal or milk, do they? Toast. Okay, there's no salt in toast. There is. And then also I find out that Mr. Jones wants to be healthy, so he has tomato juice for breakfast. Okay? So Mr. Jones might not have as good a handle on his sodium intake as he thinks. Potassium. What about potassium? In stages 1 and 2, potassium is usually limited to greater than 4,000 milligrams a day or 4 grams a day. In stage 3 and 4, the limit you can see is right here, 2 to 4 grams a day. Stage 5, 2 to 3 grams a day. Restriction in stages 1 and 2 chronic kidney disease is not used unless the blood levels of potassium rise. So in case you're wondering what foods are good sources of potassium, now potassium is really important for people if they want to be healthy. So the diet for chronic kidney disease is not the same as the diet that healthy people want to follow. All right, so there might be some confusion over that, and so you might have some questions and say, well, my doctor told me to limit my potassium. And another person in the room might say, my doctor told me I should eat a lot of potassium. This is very confusing to me. So I want to read a quote to you, a quote by Andrew Lamar with the California Association, and he said, this isn't restaurant service, and this is in regard to a special diet. You have to factor in a lot of different things because every patient is different and every situation is unique. And that's really important. The diet is different for everyone. In fact, I was working at a dialysis clinic a year ago, and a patient said to me as she was walking out, she says, I saw that man that was sitting in that chair right there eating a banana. And I was going to call the police on him, the diet police. You know, I think she wanted to report him to me. And you know, she wanted to be helpful, right? And I said, you know what? He's on a 3K bath. That means his dialysate is pulling the littlest amount of potassium out of his body. We want him to eat more potassium. He's not as well nourished as you are. And he has a different situation. So some people's kidneys are filtering the potassium out. They have what we call residual renal function. They still have some kidney function. Their kidneys are helping the dialysis procedure out. But her kidney wasn't, and so she needed a lower potassium diet. So it's different for everyone. And that's what can make it confusing. But that's why you have a dietitian to help you. So usually fluid restrictions are not required until the person gets to stage 5 dialysis. And this is information on fluids. Let's see. Blood sugar management is very important. And again, a lot of this is in your handouts. And I want to leave time for question and answers because I think that you're going to really appreciate, you know, asking me a few questions. But there's a lot of requirements with regard to carbohydrate intake and fat intake. And I didn't talk a lot about hyperlipidemia, but dyslipidemia is or high cholesterol and those kinds of things, that can really contribute to kidney damage. We talked about anemia, that's in your slides. Protein intake. The KDOQI guidelines for protein intake is 0.6 to 0.75 grams per kilogram a day for a GFR of less than 25 milliliters per minute. Now again, I can translate that into English for anybody, so just let me know if you need that information. I'll be happy to provide it for you. The MDR study is a study that was a landmark study funded by the NIH, National Institute of Health, studied varying degrees of dietary protein and phosphorus intake as well as blood pressure on disease progression, and determined that a 0.2 gram per kilogram a day reduction in dietary protein intake, that's what DPI is in this slide, was associated with a 29% slower rate of the loss of the GFR. So what foods are high in protein? You can see a few of them up on this slide here. Proteins are usually from animal sources, eggs, chicken, fish, meat, those kinds of things. So again, another slide on protein restriction and what restriction is appropriate for what stage of kidney disease. Plant protein foods decrease inflammation, so they're good for you. They improve immunity. They may slow the decline of your kidney function down. So we've got animal proteins on the left and plant proteins on the right here. So I'm going to push, I'm from Michigan where we eat meat and potatoes. But I'm here to tell you that if we could go in the direction of eating more vegetables and plants, that's going to be a healthier alternative. So it's very difficult for a Michigander like myself. When we eat a piece of chicken, we eat a lot of chicken or a lot of turkey or a lot of fish, a lot of protein. And so it's all about readaptation. And that's what's going to help people survive. And in a moving world, readaptation is the price of longevity. And that's a quote that I thought I'd put up there for you. So the best to worst proteins are on the slide here, as you can see. And I'm not saying you shouldn't have any meat or dairy. I'm just saying that this is the best to worst proteins in terms of the work that the kidney has to do to clean the blood. But this slide will show you that when you lose your kidney function, you lose your ability to produce active vitamin D in the body. And it causes too much phosphorus in the blood, the parathyroid gland in the neck. The parathyroid gland gets hyperactive and it pulls calcium and phosphorus out of the bones, and then phosphorus stays in the blood because the kidney isn't filtering it out. And so the bones release hardness because of all this, leading to brittle bones that break when you cough. So that's a brittle bone. So where do you find phosphorus in foods and you should avoid phosphorus? And phosphorus is 100% absorbable as a food additive, but it's only 60% absorbed when it occurs naturally in a food. So it's important for us to start reading the labels, and these kind of things right here, you want to look for the word phosphorus or phosphate on the labels. In all of these things, the butterball turkey is injected with sodium phosphate and phosphoric acid. So when you're plumping up a turkey, you're injecting it with these things that are plumpers and high in phosphorus, maybe high in sodium, maybe even high in potassium. So read your labels and stay away from even water beverages. If it's a sparkling water beverage, it's going to have a phosphate additive in it. Colas have a phosphate additive, but some clear beverages have phosphate additives in them now too. So there's more phosphorus now in the American food supply than there's ever been, and that's thanks to fast food. So yeah, these are all high in Bisquick baking mix, high in sodium, high in phosphorus. All these things are high in phosphorus. So the nutritional information on phosphorus, again, is in your handout. You want to limit sources to 800 to 1,000 milligrams a day when your blood level is more than 4.6. But the problem with that is the body is going to maintain a normal blood level of phosphorus at the expense of your bones. So you won't see a blood level of phosphorus going too high until it's way too late. The horse is already out of the barn. So phosphorus restriction and protein restriction should come early in chronic kidney disease. If you're limiting your protein, you're automatically limiting your phosphorus. So the story with phosphorus, and probably the two most important nutrients to talk about today, would be protein and phosphorus, because there's a 15% increase in phosphate additives in the food supply in the last 10 years. It's a huge public health issue that the public doesn't know about. Dietitians have lobbied Congress and lobbied the government to put phosphate labeling on foods, and they won't do it because they say that there's not enough pressure from you, the consumer. So I go to Washington all the time. I am active, and I cannot, my colleagues, my registered dietitian colleagues, the American Dietetic Association, we can't do it without you. If you're not aware of this problem and you don't tell people that this is an issue and you want this on the label, they aren't going to change the rules. And that's the long and short of it. So it's not required to be listed on the food labels. There's a lot of hidden sources. The benefits can even be seen when blood values are normal. Of restricting phosphorus, the benefits can be seen when your blood values are normal. And high phosphorus foods are listed right here: milk, cheese, pudding, custard, baked goods, fast foods, and so on. But we don't want high calcium in your blood. And then vitamins and minerals, stage 3, stage 4, what to do. Stage 4, you should be definitely on a renal multivitamin. Other nutrients that might be important for people with kidney disease: omega-3 fatty acids, vitamin D3, coenzyme Q10, and L-carnitine. In summary, and now I've got about 4 summary slides, I just wanted to say that if you have chronic kidney disease or risk factors, really see a registered dietitian who can help you lower or eliminate your risk. If you don't get a referral from a physician, find a dietitian anyway. The dietitian will help you contact your physician and get a referral, but do see a registered dietitian. Eating and lifestyle changes should start as early as possible, even before stage 3 chronic kidney disease, and for sure at least 2 years before dialysis has begun. Medical nutrition therapy, blood pressure, and blood sugar control can delay the progression of kidney disease. And people must be motivated and carefully monitored, and I want to stress that, carefully monitored by a registered dietitian. That's why one visit is not enough. For optimum health with kidney disease, in summary, low sodium diet, modified phosphorus, limiting animal protein, choose lots of plant protein, way more than one per day if you can. Well, depends on your potassium level, but anyway, high protein diet is only for dialysis or peritoneal dialysis. Potassium restriction is individualized, and fluid restriction is for stage 5 only. What can you do? You can do all of the things here. Control blood sugar, control blood pressure, see an RD and discover your individualized nutrition prescription. Learn all you can about your nutritional needs by making an appointment, and improve your fitness level. Seek professional guidance if you need to. Get your blood test results, check your fitness level, find out how you can become more fit, and control your blood pressure. I want to leave you with this quote by Oliver Wendell Holmes, that having a chronic disease and taking care of it is the definition of longevity. In other words, longevity is having a chronic disease and taking care of it. So on that, I'll take questions. Thank you very much. Yes, sir.
I can't remember where, but I heard that soy was actually had too much of something else. That's in the phosphorus, I don't know. But you say it's good for protein source?
The question was, I guess I don't need the mic for him. The question was that you had heard that soy is actually high in something, and you can't quite recall what it was that it was high in, but you know it's high in something. Soy can have soy is a very high quality protein. We didn't used to think that soy protein was a complete protein, but we now know that it is a high quality protein. And so that's one important thing. The other thing is about soy is it can often be a good source of phosphorus and potassium. So I have lists for my patients that I give them listing the potassium and phosphorus content of soy, different soy products. And I also have a list that tells them what can they eat if they don't want meat, and in terms of soy products. But it also lists the potassium and phosphorus content of those products. So some of my patients, the most difficult thing for them is controlling their phosphorus level in their blood. And they want to start adding soy proteins, but their phosphorus level is high. So I help give them guidance on how to navigate those waters. Does that help?
Yes, so it's phosphorus and potassium are the culprits.
That's right. It is phosphorus and potassium that would be the culprits. But having said that, I have a lady right now on a vegan diet. She's on 20 grams of protein a day. Please don't try this at home without supervision and asking your physician. And her phosphorus level is absolutely not an issue at all. And she was a huge meat eater. Huge meat eater. Cheese, meat. And when I first saw her for the first time, she looked like a deer in the headlights. And I know that look because I've had that myself. When I told her that a vegan diet would keep her off of dialysis, I know that it really upset the apple cart, so to speak. But she can eat soy proteins and all kinds of foods and not have to worry about anything, because it's just not an issue because of the diet she's on. I hope that helps. Yes, ma'am.
Wouldn't it be possible to use phosphonol and Caxylate?
Absolutely. The question is, would it be possible to use phosphonol? Phosphonol is a phosphate binder. It's one of the strongest binders on the market. It's like a magnet that binds phosphorus really strongly. So you take it whenever you eat a meal, and it's like a magnet. It'll pull phosphorus out of the meal you ate in your intestinal tract. That's how that drug works. It gets phosphorus before it even gets into the blood. So you can take phosphonol to bind the phosphorus, and I use that as, you know, one of my little weapons in my armamentarium is phosphonol and other phosphorus binders as well. So you can use that. And in Caxylate, you can use that too. Caxylate is a binder for potassium. So when I have a patient whose potassium is running really high in their blood, we might use Caxylate. It's not our first choice. We don't like to use Caxylate. It's not a good idea at all. It's a horrible idea. but it might keep the patient alive. And so we use it for that reason. So backing up a little bit on potassium, the best thing to do is to control the potassium in your diet. That's the best thing to do. If the person doesn't control the potassium in their diet, then we can change the bath. In the dialysis procedure, there's a bath that bathes the blood, that pulls the waste products out of the blood, and we can change the bath to a 1K bath, which means we're going to pull the maximum amount of potassium out of that patient's blood. If the potassium is still high in that patient's blood, then we are forced to use K-exalate. It's a bad idea. Doesn't taste good. It's dangerous for the patient. The patient's really walking a fine line. So, dangerous, dangerous. Anyway, I hope that helps. Yes?
At what stage would you recommend using phosphorol?
Phosphorol?
Phosphorol.
Okay, there are different phosphate binders on the market. That's one of others. What stage would I recommend using phosphorol? Probably, I would recommend it when I start to see my patient's blood level of phosphorus go above 4.6, 4.7, that's when I start using phosphorol. So there's the ways to remove phosphorus from the blood are never get it in there to begin with, and the way it gets in the blood is through diet. So the second way to get phosphorus out of the blood is through the dialysis procedure, and that doesn't work all that well because phosphorus is a large molecule and it's not removed from the dialysis machine very readily. So the next way to remove phosphorus is to use a medication called a phosphate binder, a phosphorus binder, like the one you mentioned. And it's very important to make sure that the patient is taking it correctly, because when I first tell a patient to take a phosphorus binder, under the direction of a physician, of course, the patient often doesn't take it as prescribed. They're hearing so many things, it's confusing, and so they're taking it when they're not eating. Well, a phosphorus binder, if it's taken between meals, it doesn't work, because its job is it's a magnet to pull phosphorus out of your tummy, out of your intestinal tract, out of your stomach, into your feces, and it goes out. You excrete it that way. That's what a phosphorus binder does. So if a patient is not taking enough phosphorus binders, or is not taking them at the proper times, like example when they eat, then they still have a high blood level of phosphorus. Does that answer your question?
Well, like stage 3, 4, 5.
What stage would I recommend it? I don't go by the stage. What I do is I go by, I'm a medical nutrition therapist, so I believe that nutrition is medicine. I can cure most anything with nutrition. But there's many things I can't do with nutrition. And when I can't, then I use medicines. And so, under the direction of a physician, of course. So I don't just, but probably you would probably start to see high phosphorus in stage 3. To answer your question, that's where I'd be looking for it. You're welcome. Yes?
What is the ideal potassium rating for a kidney patient?
What is the ideal potassium rating for a kidney patient is the question. And I think what your question is how many milligrams should a patient have a day of potassium? Is that what you mean?
No, the blood test.
Oh, the blood test.
It gives a reading.
Okay, very good. So you want to know what a normal level of potassium is in someone's blood?
For the kidney patients.
Sure. Well, probably between 3.5 at the low end. You don't want to go below 3.5. That can be bad too. Low potassium is just as dangerous as high potassium. So you don't want to go below 3.5 and you don't want to go above, let's say, 5 or 5.5. Okay?
Thank you.
Yeah, talk with your doctor. And I saw your hand go up, sir.
Yeah, I was curious about, in the morning I've been doing almond milk with like rice cereals and nuts. How is almond milk versus rice milk?
I like almond milk I think it's great. What are you on, dialysis or pre-dialysis or?
I got polycystic.
Polycystic, okay. I would stick with the almond milk. That's much better for you. The rice milk doesn't have any nutritional value for you. You want the almond milk in your case, absolutely. You see how I can tell more, if I know about a person, if I know what their disease situation is, if I know what their blood work is, if I know their medical history, I'm a lot more helpful. This diet really has to be individualized. You just can't make blanket recommendations like this for everybody, so thank you very much. Thank you all for your attention today, I sure appreciate it.